We have here today Pramit Patel. He's joined us from Surrey, from Clare's Manor. He's Executive Primary Care Leader for Surrey Heartlands ICS. And we have Thorrun Govind, who's the Chair of the Royal Pharmaceutical Society. And you came to my attention when we were putting this together, Thorrun, because I saw your responses to the announcement by Barclay about increasing the role of community pharmacists in prescribing and in supporting patients. And I think you had some really good things to say, so it'd be just really, really nice to hear those now. So Pramit, do you want to go first?
Good afternoon, everyone, and thank you for having me. So Angela very kindly just introduced me. So as well as being the exec primary care clinical lead, I'm a GP partner in Surrey. I'm also a clinical director for a primary care network, as well as being a trustee at NHS Confed on behalf of primary care. So there's a bit of a journey there, which I think is important to sort of just go through. So I think one of the questions, Angela, you asked is, how do we reach the NHS goals in terms of out-of-hospital care? And I suppose Simon Stevens said, didn't he, before he left, that if general practice fails, NHS fails. But general or primary care rather, is just wider than general practice. And I'm looking at my good friend Ursula Montgomery there in the green. Primary care is general practice, pharmacy, optometry, dentistry, and Claire would say audiology as well. Is that right, Ursula, when it came to full stock take? So really it's understanding how do all those elements of primary care come together when it comes to delivery of care services. And I think there are three things that I would say we need. One is a coordinated, integrated out-of-hospital clinical pathways with clear lines of accountability and responsibility. And I suppose it's really about bringing the twins back together again. When I say the twins, I mean general practice and community services, because a lot of the delivery in integrated neighbourhood teams is about general practice interfacing with other healthcare providers within those footprints. We've talked about upstream work, but what does that really mean? You know, upstream prevention, using PHM data, but it's more than just data. It's the insights and the science behind the data. And I think, Angela, I think there's a bit of a lack in terms of resource within the NHS in terms of that data science piece, and how do we actually use BI and really max out the data that really is powerful. And it's how then do we co-design those interventions with local authority, because it's really about demedicalising poverty as well. And I've spoken about BI, it needs strong leadership at all levels. So it needs strong leadership from general practice through to community, system and beyond. And really, I think it's incumbent on all of us to find that golden thread right through from the bottom to the top. So therefore, if we're able to influence policy, we'll be able to deliver it on the ground as well. So I think, Angela, they're the three things I just really wanted to touch on in terms of what can we do in the out-of-hospital space.
So I'm Thorrun Govind. I am a pharmacist, community pharmacist. I am a healthcare lawyer, and I've just finished my tenure as chair of the Royal Pharmaceutical Society in England a few weeks ago. Pharmacy first, yeah, you talked there about describing it as game-changing, and Steve Barclay picking up on that. And I think it comes back to this whole point of, if we keep working in these silos that have developed, ultimately the patient suffers, and we end up with these uncoordinated ways of working where we get a bit frustrated at each other, and it just doesn't work very well. So we're really pleased to see Pharmacy First, which is the idea that 7 common conditions will be able to be dealt with in the community pharmacy. That was announced, but obviously we're still waiting for all the negotiations, as all that always happens. We get the announcement and then we wait with bated breath, don't we, for the negotiations and that actually to develop. But I think it comes down to the patient flow as well. How are we seeing people coming in through, where is the front door to the NHS? Because everyone seems a bit confused. Is it 111? Is it general practice? Is it pharmacy? Is it an app in the future? Are we just going to tell everyone to log on to their app and that's it? And ultimately, I think we need to be better between ourselves at deciding or encouraging patients to go where they're needed. So for about 10 years plus now, I've been speaking about pharmacy in the media. And actually, I had a doctor say to me recently, I'm really pleased when I see you on there because I get annoyed at some of the things that some of the TV doctors are talking about, because actually they're things that people need to be seeing a pharmacist for. So they need to see a pharmacist in that position talking about that, so they know when it's just general hay fever, or this morning I was talking about insect bites. That's something that in general practice probably shouldn't be dealing with. Your pharmacist should be providing you with that advice. But then there's that teamwork element of when should I be referring a patient on to general practice? Or even more importantly, when should I be telling a patient this is a life-threatening emergency, and teaching them and educating them about where they need to access services. In terms of pharmacy, in terms of pharmacy first as well, we sadly still don't have those integrated care records, so shared care records. So we're really keen to see that. And then I think we need to look across the nations as well. I think I'm frustrated in England as a community pharmacist because look what's happening in Scotland or Wales, where they've got independent prescribers geared up. There's commissioning in place to support that. And we are going to be having independent prescribers coming out in England 2026. Pharmacists are going to be leaving and being able to prescribe. And I think we could start to get worried about this. And sometimes I see too much criticism of other professions, and actually then that undermines all of us, doesn't it? We actually need to say, well, actually, if we're all prescribing within our competence, then actually we need to be supporting each other to prescribe within our competence. And if we see areas of where things aren't going so well, it's in our professional interest to actually have a conversation with that individual, have a conversation in the local area. But instead, far too often I see it playing out on the internet, and I think, who's actually had a conversation with that individual and then explained to them the practice? So I'd love to hear more as well about your sort of thoughts on that as well.
Yep, I totally agree, and I suppose integration can only happen through relationship building. And I think one of the things that we are focusing in Surrey is aligning the community pharmacist network lead with a clinical pharmacist from the PCN within all 25 PCNs. And therefore, once they develop those trusted relationships, then they can start thinking and talking about those end-to-end pathways. And I suppose the key thing for us really is the patient journey. What we don't want is patients being handed off. So if they go to pharmacy and because it's not the right thing, they go to the GP or vice versa. So that front door, that streaming and redirection, I think is critical. Because if we're confused about the front door, God only knows what our patients think.
Exactly that. Did I pick up a question there? No? Can I then just sort of knit some of this together? So I'd like to talk about the strategic role of LPCs in ICS systems, because hopefully, they are included in those systems. And are they included in those systems, local pharmaceutical committees? So
in terms of local pharmaceutical committees, obviously, again, we probably don't know here how commissioning works and sort of funding works for pharmacy, but let me give you a sort of quick run over of that. So you've got Community Pharmacy England, who used to be called the Pharmaceutical Services Negotiating Committee. Really glad they've changed their name. It's a mouthful. And then they are obviously they're negotiating at a national level. And then you've got the local pharmaceutical committees who, are sort of the structure underneath them. But obviously all those knitted together create this pharmacy network. And I have served on an LPC. And you've got people from different backgrounds. So you've got your independent pharmacists, you've got your multiple pharmacists. So you've got pharmacists coming in from different angles, different pressures on them. And your independent pharmacist might be a one-man band, effectively. They've got different pressures on them compared to, say, a Boots or a Lloyd's. So I think that obviously there is variation between the LPCs across the country. Some of them are really good at negotiating with their local commissioning services, but obviously for some of them that's a bit of a different position. It also depends on how keen the local commissioners are as well. And I just wanted to come back to one point you said earlier, which is sometimes I think we see a community pharmacist in one, and then we see a clinical pharmacist, and it's like, how come if I work in a different building, there's a different perception of me? It's like, do my skills immediately disappear as soon as I walk out of a GP surgery?
Good point. that actually brings me, Thorrun, very nicely to the point about what was the evidence behind the 7 common conditions that this was actually going to make a jot of difference to the capacity of primary care, and actually playing to the skills of, pharmacists who spent X many years specialising in medicine when most GPs only spend a matter of months in their training.
So we know there's been pilots of this scheme across the country. We've seen how it's worked we've seen how sort of common conditions are dealt with in Scotland and Wales. Yeah. So I think that's a key part of the evidence behind it. I personally don't think it goes far enough. I was in practice, somebody needed fungal nail treatment. I know they need that. It all works out well. They turn around and say to me, well, I'm going to be on it for 6 months or 12 months. I'll go and see my prescriber. How? Why? It doesn't make sense, does it? So why can't the prescribing, this is my dream utopia of being able to share the prescribing budget in some way so that actually that patient doesn't need to waste a GP appointment or a prescriber appointment. I try and say prescriber now because actually we've got nurse prescribers, pharmacist prescribers. So I'm trying to be more inclusive with my language as well. Because although you're GPs, you're fabulous, you aren't the only people in the team. So, we've got to make sure that we're also educating our patients about the different people within the team, because GPs can't see everybody.
Right. And I think you make a good point there, though, on integration and that clinical pharmacy piece. And, we have over 400 clinical pharmacists at the moment working on upstream, finding people using things like Abtrace, Cardiac Prevent, all of that, and that those undiagnosed people, being able to prescribe. I love the fact that you made the point that I thought it was by 2025, but is it 2026 that all graduating pharmacists will be independent prescribers, which is a great step forward. And that's right across the UK?
Yes, and it's fantastic. But again, we need the pipeline in place because they're going to come out, they're going to come into community pharmacy per se, and then they're going to think, well, I can't use that.
No. What about the other elephant in the room then? A pharmacy a week is closing down. How on earth have you got the time to do this stuff?
Well, our teams are at risk at burnout. We've got retention problems just like the rest of the NHS. So really it's about empowering the teams, isn't it? So that actually people want to stay. They feel like they don't need to move into general practice to be able to use their prescribing skills. So I think it's about empowering the pharmacist. Something as simple as I can't even change from tablets to capsules if it's on the prescription. I think it's pathetic, and I think that we've let this go on for too long now. Medicine shortages, increasing problem. It's a problem for us. Then they go to the GP. Problem for the GP because we're waiting for those serious shortage protocols to be issued. Well, I'm sorry. I think that by the time that the government sometimes find out about it or Parliament finds out about it, the ship has sailed. We've had all our patients already in. I've had women. I've done a lot of work with HRT, for example, working with campaigners. Menopause Mandates, a campaign group that I work with. Maria Fostrup and Carol Boardman and all those, and they are talking to me about the shortages, and then I've had the women coming in, and it's heartbreaking when you see the impact it's having, medicine shortages, on the patients.
I'll give you a data side to that. We were called by the Department of Health last April. The Minister urgently wants us to talk to you about the HRT issue, and so you can give us all your data from around the world, where it's got HRT, where we can get it from, blah, blah, blah. Come in and talk to us. So we did, put all our, got data from all over the world about where we could get HRT into the country, blah, 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 without causing problems elsewhere. So had a lovely chat, and then we said, but we can do better than that. We can give you, because we've got supply chain all around the world, an early alert system, and we'll build that for you. Yeah, bye, sort the problem. And then when we had the amoxicillin thing, and Steve Barclay was on, I was listening on Radio 4 that morning, and he's going, don't worry, the department tell me we're going to have amoxicillin. We're all right. There's not a shortage. Now, literally, I got our team on it, and within 24 hours, we were able to say where the problems were and what was going to predict what was going to happen in another week if he didn't sort the problems of stockpiling, blah, blah, blah. Yeah? And, again, it's just that kind of like, somebody said it in the previous piece about, bringing the centre together. And, making the centre work together. And when you've got partners that can help you and help you free of charge, come on, guys. Yeah, that collaboration piece. In terms... Go.
Can I just come back to the previous question? You talked about ICSs and what's their role in terms of strategy and LPC partners. So one of the things that we did early on is understanding the role of the partner member on the ICB, okay, the primary care partner member. How can they go onto the ICB representing the full breadth of primary care if they don't have the right expertise and knowledge for those individual professions? So one thing that we did very early on was create something called the Primary Care Provider Advisorate. So this brings together members from the LPC, LMC, LDC, as well as the Director for Primary Care. And essentially they come together once a month, talk about those conditions. Right, okay, we've got these 7 conditions coming online. We've got CPCS, the Pharmacy Consultation Service. What's the difference? Okay, one's a referral mechanism, one's a pharmacy first mechanism. How do we actually square this off? What's the role of GPs? And having those people within the same room talking about those end-to-end pathways with the patient in the middle actually then generates a different conversation. It goes from a transactional conversation to a transformative conversation. So the role of the ICB is creating the conditions for those conversations to happen.
And this kind of thing, really needs expanded and written up, right, and shared. So thank you for that, Pramit. Questions from the audience, please.
Thanks. Matthew Winnington, I'm Cabinet Member for Community Wellbeing, Health and Care at Portsmouth City Council. I've got a 2-part question here. So one of them is really about, for you, Pramit, in particular about thinking about how when you're working at integrated care system level, obviously a lot of the things that are to do with primary care are done at a place level. So obviously at Health and Wellbeing Board level, which in our case obviously is Portsmouth, and we have 4 in our integrated care system in Hampshire. How do you feel that can work together better in that way, and how does the response for things like pharmaceutical needs assessments, which of course are done at Health and Wellbeing Board level, how can that fit into the integrated care system as a whole? And also, it's just a bit of an example about in Portsmouth, we have Health and Care Portsmouth, which is an integrated team between all the parts of the NHS and the City Council in the city. But we've done a lot of work in talking about the team around the person. So primary care as the whole of primary care, and yet the government has done that massive campaign last year, which was all about making it about go and see your GP. So what are the things that we can do as parts of integrated care systems to really have that voice up to government and say, you're actually making problems for us down here because your messaging is not fitting what actually we all need to be working on?
Really good question. And I suppose, so an ICS in Surrey is different to an ICS in Bob, is different in Frimley, for example. So in Surrey, we're fortunate, we're coterminous with our local authority, okay? And our chair of the ICP is Tim Oliver, who's a council leader, and he also sits on the ICB. So in terms of the primary care piece, we've kept it across the whole system, which covers a population of 1.2. You can do that with a smaller ICS when it gets bigger, such as the North East and Cumbria ones. When you've got 3 million, you probably do need to segment into different places. So what is a place for us in Surrey is very different to what a place is in other ICSs. I suppose the question really is how do we communicate upwards and then make sure it feels real and right downwards? And I suppose that comes back to the theme I always go on about is relationships and leadership, and having that connection with the right people within your system is critical. So for me, it's having a connection with Tim. So I do have one-to-ones with Tim. Claire is my line manager. I have a one-to-one with the ICB chair as well. In fact, Ian Smith, the chair, constantly he badgers me, can we go on the road? And I want to go and see general practice, I want to go and see practice, I want to go and see pharmacies. So I end up being a chauffeur around Surrey, taking him to practices and so forth. But it's those are the times where you create the relationships and you can have those sort of corridor conversations. Because we've sort of moved into agile working and teams and so forth, it's quite transactional. So I think, having those relationships, I think is critical and it's key, but it takes effort. And I suppose that's something which I do think we as system leaders need to try and sort of work through. When we look at the pipeline of our leaders, that needs to be integral.
Any other questions for Pramit and Thorrun? Thank you.
So, hello. First, I would like to thank the panel for this insightful discussion. I'm Exia Ganaho. I'm a pharmacist from background. I was working as a clinical pharmacist before coming here in the UK. I'm studying currently at UCL. So my question is, you were thinking about rising the number of independent prescribers. And I want to understand, what do you think might be the downside of this? Because currently this is not really, we think this may be good for the health system in general, to give this kind of freedom to pharmacists. But what do you think might be the direct consequences? And you were also talking about empowering pharmacists. So what is to be done in real life? Like in the regulatory aspect, what is to be done really to give that power to pharmacists today?
Okay. Well, let me take the second part of the question first. So something as simple as allowing us to make switches between tablets and capsules and be able to endorse so that we get paid for the item that we hand out. That's just a simple thing, the first thing that I can think of immediately right now. I think in terms of, as well, the read-write access to records, that's another quick win. Well, I say quick win, I've been waiting for it for about 10 years. So I think there's things that could be done which would help with integration so much better, like when we do a flu vaccine, right? Why can't I just write that straight onto the patient's record in the general practice in my community pharmacy? Because there's this whole issue about sharing records, even though if you're in a GP surgery, you're held to the same standards as me. You're going to be, if you do something wrong, you go to the GMC, GPHC. We're all regulated professionals, and I think there just needs to start to be an element of trust, because I do think there is a bit of an element of trust lacking within the system. And then the downsides of independent prescribing. Well, ultimately, again, if we haven't got that access to be able to share the information, that poses a risk to patients, perhaps clinical negligence, perhaps if there is a prescriber giving something out here and then that information is not adequately shared with the GP record, for example. So that's one example. But ultimately, I think in terms of we have independent prescribers who are currently working in general practice, who are pharmacists. So again, it takes me back to this same position. Are we less valuable because we work in a different building? Do my skills disappear as soon as I walk out of a building? Ultimately, we need that trust in the system. And we need to realise that ultimately there aren't enough of us who our retention is a problem. So if people aren't going to feel empowered, and that's part of burnout, isn't it? If we think about what burnout is, it's feeling like you can't actually do what you're trying to do. It's feeling like you're not valued. It's feeling like you're not getting anywhere within the system. So are we actually forcing burnout on our clinicians because we're actually not supporting them? We've seen a problem now with records. Why are we not rectifying that issue?
100%. Anything to add to that?
I think the future really is the rotational post, Thorrun.
Yeah.
So when we think about teams of teams within integrated neighbourhood team footprints, is how do we create those rotational posts so we're not stealing from Peter Papal, and ultimately there is that teamwork ethos, and through that I reckon will come the data integration. So you can deliver integrated care through having integrated data sets, right? So there needs to be a bit of both. So the human element and the data element to bring it all together.
100%. Any other questions?
I think, first of all, from a position of being a massive fan of what prescribing pharmacist is going to bring and achieve, but what you're now asking is for a population who less than a generation ago knew the name of the person they would go to now trust a process, not a go-to person. So we know our experience of primary care is that typically we wouldn't expect now to see the same GP consistently. But it's the reality of being a citizen in that environment. But this is then another front door. We either need to give somebody a person to trust, or we need to create a process that we articulate that we can trust. So I suppose I just welcome your view on that. How do we create trust in the process if that's the nature of the healthcare we're going to offer?
Okay. So I think that's about us as individuals supporting the system. So if I'm a pharmacist and I know that what the patient in front of me needs to see a GP, I need to be honest and transparent with that patient and say, this issue that you've come to me with needs to be seen by a GP for maybe X, Y, Z. If you see that patient as a GP and you know it's an issue that should be dealt with by a pharmacist, you should be saying, actually, for the best, it's great that you're here, but actually, I need you to go and see that pharmacist about that issue. So yeah, they might have come into you, it's a 10-minute appointment, right? But ultimately, perhaps it would be in the best interest of that patient to go and see the pharmacist, because you are building trust in the system. Then next time they have that issue, they will go to the pharmacist instead. We have to work around how we educate our patients and the public. Things have changed. We can't go back to where we are. We have to work together to make a difference to how people access the NHS. And again, with these conversations that I've been having with TV doctors, for example, this morning, for example, a TV doctor was meant to be speaking about insect bites, and she said to the producer, she said, I'm not sure that you should be talking to me. I think you should be talking to a pharmacist. And actually, that was a very powerful thing for her to say, because that's supporting pharmacists. So just like I need to be saying in some situations, actually, no, you need to be going to your optician about this. I can't look into the back of your eye. So we're training patients with where to go with every interaction that we take.
I think you raise a really good point though, Adam, and it took me back to what Chris Hobson said, and a little bit of what Patricia Hewitt talked about, as well as Claire. So, how far the traditional role of the GP-led partner practice being the front door to the service. And then Chris talked about integrated pathway design with multidisciplinary teams and the importance, and he called it out, access, triage and navigation. Yep. And that word navigation, and whenever we talk, and you'll always have your N=1 of your experience, it's, I didn't know where to go. And we've got people here from social care today, and that's a whole other ball game. So that kind of, what was it? Access, triage and navigation, and having that kind of single point is the way forward, because, we are not going to have, going forward, 75 years on, a situation of this kind of adult-child relationship between the GP and the patient. And Dr. Leggett's gone now, I know, but felt very strongly about the patient's role and citizens' role in taking responsibility for their own care.
Sorry, I was just going to come at this from my personal experience. So I had plantar fasciitis and I was trying to access the healthcare system, and I would have thought I was quite an informed person about the healthcare system, but no, I was not. I got sent to somewhere which wasn't easy to access. So I got told, you'll have to change your GP practice to be able to go to where you want to go to. So I changed my GP practice and the appointment got cancelled at the place that I was originally planning to go without them telling me. And then I ended up in A&E, and they said, no, we can't refer you, and unless it's fractured, we can't refer you, you need to go and get an appointment with your GP. So isn't that ridiculous? From A&E, I'm being told to go to my GP. So at that point, I was almost like, would you like me to fracture my foot outside A&E at this point so you can refer me to where I need to go? And that's my experience as someone
kick the desk.
Well, I was tempted, but that was one experience. And I was stuck within a system of booking, call this number, NHS, the number, book in with this system. And I'm relatively educated, and there's a whole literacy, we've not even touched on health inequalities, and varying levels of literacy as well, who are trying to access our systems.
100%.
I'm
going to give you the last word.
Yeah, I really just want to just share some stats, in fact, and I think we spoke about this before as well.
We did.
Angela, so Claire referenced, I think she referenced it, she may not have referenced it. There's a 1% work that we carried out in Surrey. So if I just give you a bit of a breakdown. So Surrey is broken into 4 places, okay? And one particular place is around about 220,000 citizens, residents. Now, when our data, our PHM experts did some data crunching, out of that 220,000, 62,400 people were identified as high users of healthcare services. So 62,400 within a 12-month period. 1% of that population, so 624, had in the previous 12 months 1,900 A&E attendances, 500 outpatient appointments, 500 inpatient stays. Now, do you mind if I ask the audience the next question? And you're not allowed to say anything, Ursula Montgomery. So how many contacts do you think that 624 cohort had in general practice? Not primary care, but general practice within that same period. Just some shout out answers from the audience. I'll be really interested to hear. 18,000.
Higher? Lower?
No, carry on. Oh, you've done this. You know the stats, don't you? Okay, you're right. It's 54,000 contacts, okay, for that same cohort. That's staggering, right, for such a small population. And therefore, that told us we're not doing something right in terms of the care pathways and the operating model. So we looked into that 624 cohort and looked into why they're going, where they're going. But before that, we identified what their needs were. So 75% of that 624 were actually severely frail, okay? So what did we do? We created a PCN frailty service, okay? And within that PCN frailty service, we had a care coordinator that became the single point of access for that population. We had clinical pharmacists that were part of the MDT. We had social prescriber link workers as well. We had physician associates that could do the proactive geriatric assessments in the community in their own homes, Angela. We had a GP who was working 3 days a week supporting this team. So that's the general practice contribution. But docked into that, we had the community geriatrician from the Acute Trust. We had the community matrons from the Community Trust, and they themselves created that MDT, that community-based MDT. And actually being proactive with that cohort, we saw a 12% reduction in admissions in the first 2 quarters. We've also seen a 20 to 30% reduction in general practice contacts. And it's because I think it goes back to what Chris was saying, single point of access. Yeah. That care coordinator is the linchpin for that particular cohort. If it went through, if the contacts go through that person, they can make sure that person is seen by the right person in the right place first time round. You're not doubling activity for the same demand. And that's what we're guilty of that in the NHS.
Yes. Pramit, from the point of saying, Houston, we've got a problem, or sorry, we've got a problem, to actually getting those kind of turnarounds and getting the service up, what kind of time period are we talking about?
So we did some work pre-PCN where we engaged with the King's Fund to do some change process stuff, okay, within our PCNs. So they came, we had action learning sets, we sort of talked through the why, the what, and the how. And it really was a journey bringing people together. And it goes back, I'll go full circle, it comes down to relationships ultimately. If I don't know the geriatrician, if I don't know the pharmacist, if I don't know the matrons, how can I create that end-to-end integrated pathway? And I suppose for me, it's really about understanding your data. It goes back to what Chris was saying, understand your data, use that to then influence and inform what your services should be, and then map your workforce accordingly. Otherwise, if you don't have the data, you're walking blind. And I think that's
I'm gonna be that person.
Yeah.
How long? I know you did a bit of pre-work, but when you really said, Houston, we've got a problem, it looks
we
like
started
this
journey with those selected PCNs in 2019.
Yeah, brilliant. It's pretty good. So you worked it, you took it through COVID.
Took it through COVID.
Boom.
And do you know what the beautiful thing was, Angela, was that digital was great in some respects because those MDTs came together virtually, and because you could actually bring a patient and the carer into the conversation, you're not talking about them, you're talking to them and talking with them.
And there was a lot to be said for digital meetings, weren't they? Much more efficient and so on and so forth. I'm going to draw this session to a close. We've got 2 more poll questions, and then we've got a wonderful team from London who are going to keep you spellbound, I know, because I had the briefing from them yesterday. They're going to tell it as it is, which I really, really liked. But before I do that, can I thank Pramit and Thorrun for the session that they've done today.